Good evening, everyone, for joining our AOEC webinars today. This is our sixth webinars, which is on the 10th of July. And our first talks is by Dr. Dunne from Australia, and his topic is first seizure evaluations and management. I would like to introduce Dunne. John is the current chair of the ILAE Asian Oceanians Commissions, and he is the world expert and has many publications on first seizures. Let's listen to his talk on first seizures evaluations and management.
Oh, good. Hey, good morning, everyone. And just to say, Chen is the boss, really. She asks, I do something, I do it. Very simple. So we're going to talk about first seizure, its evaluation and management, and there are many beliefs about first seizure, but some of them are not true. And so I'm going to be looking at facts. Now, here is the arrow pointing to my home in Perth, Western Australia, a long, long way away. That is the beach near my home. And even though we have such a big distance, we all face many patients who present with a first seizure or something that might be a seizure. And 1 in 10 people will have a seizure in their life. It may be unprovoked or it may be acute symptomatic. So that means an annual incidence of 1 in 10,000 people. Many, many people will seek our advice. And a first seizure is very frightening to family and friends. They think their loved one may be dying during a seizure, so they need our help. So what are our goals? Was this event an epileptic seizure or not? If it is a seizure, what type of seizure? This will guide our management. Was it focal or generalised? If it is a seizure, is it an acute symptomatic seizure or unprovoked? This is very important. Seizures are only a symptom, like headache. If someone has a seizure from herpes encephalitis, treating the seizure does not help, does not rescue the person. And most importantly, if it's not a seizure, what was it? So, I have great fortune to have Nicholas Lorne, a New Zealander who moved to Perth, my home. And in a prospective study over many years, we've evaluated almost 4,000 patients in the first seizure clinic, almost 2,000 with an actual first unprovoked seizure. So, first question, fact or fiction? Is a first seizure a clinical diagnosis? Now, of course, we all will agree, yes, and I can confirm we're all right. The patient and eyewitness account is the single most important diagnostic test. We do not need other diagnostic tests. And now, in the days of smartphone, family may even show us a video, which is very powerful. Accurate diagnosis of a first seizure is not difficult, as long as we take a good history from the person, witnesses and family. Now this takes time and skill. Sadly, ordering tests is much faster, and this is a problem. Tests are overrated by patients. Do a scan, doctor. Do an EEG, doctor. Bad medicine is taking a poor history and having faith in technology. So first question, was it a seizure? Now in our 3,700 patients, about 70% actually had a seizure based on a careful history. Almost 30% in the first seizure clinic did not have a seizure. And of course many of those, it was syncope. A syncope with convulsive movements is the commonest cause of loss of consciousness and is often misdiagnosed in epilepsy. And as some of you know, when I was a fourth-year medical student in the emergency department watching a scalp being the site of blood, they said, "John, you're looking a little bit pale," and I was feeling a bit sweaty. I fell to the ground and shook, and of course it was convulsive syncope, not a seizure. Syncope, half of us will have syncope, and 30% it will recur. And it is convulsive 90% of the time. This is not an epileptic seizure in ischemic cortex. If I have an EEG during syncope, the brainwave activity becomes flat. The convulsive movements are brainstem release reflexes. And here are some medical students from Germany having convulsive syncope. She falls, irregular shaking stops, and then she starts to count. She quick return of consciousness. The convulsive movements are irregular, shock-like, and the person may groan during the event, beginning, crash to the ground, irregular shaking. Syncope, convulsive syncope. Now, people can fall gracefully, and you'll notice all of the cushions because the fall may not be so safe. And this young man, the last one I show you, watch his head, bang. And so syncope, you can injure yourself. And so do not be fooled. Syncope can be quite, at times, dangerous. The movements are fragmentary, have you seen? Rapid recovery unless you have a head injury or your friends keep you standing up. And the other very important question is, when did you awake? John, you were in the emergency department, you saw a sight of blood, you wake up on the floor in emergency department. Maybe that's syncope, maybe that's a seizure. More history will tell us. John, you fell on the train station. First thing I remember is in an ambulance, a long recovery. That is a red flag, maybe not syncope. So, the first recognised seizure may not necessarily be the first seizure. Again, history is important. 30% of our so-called first seizure patients with careful history had prior seizures. That is, they had epilepsy. And so this is a very important thing as well. We need to drill down with history. This will help us determine whether syncope has occurred and whether this is, if it's a seizure, it's really the first seizure. So, it is a clinical diagnosis, we all know, but be prepared to disagree with your colleagues. My emergency centre colleagues were sending all these patients with syncope to the first seizure clinic, and we had to disagree with them. And if you don't know the answer, we wait and see. It's better to wait and have more information than misdiagnosis. Now, second question, what if somebody has seizure, 10 minutes later, another seizure, 1 hour later, another seizure? Does this mean that they have epilepsy? If multiple seizures occur within 24 hours. And in fact, the Canfields, back in 2000, made a statement that of children, if they had more than 2 seizures on one day, you could diagnose epilepsy. But in fact, this is not correct. This is fiction. And in our own data, this is Lei Kun Ko, one of our fellows did this a number of years ago. For first unprovoked seizure, the blue line is a single seizure, the red line is multiple seizures within 24 hours, and the recurrence rate is no different. So multiple seizures within 24 hours you must regard as a single seizure event. Multiple first unprovoked seizures within 24 hours do not predict seizure recurrence. A single and a cluster of seizures have the same recurrence rate. Now, do patients with first seizure need an EEG? And as some of you know, I love EEG and I'd like to promote it. And by the way, this is 1959, the first EEG in my hospital, Royal Perth Hospital. And now in 2025, it is still the most valuable laboratory test we have in epilepsy and impaired consciousness. But would you order one after a first seizure? Well, in the Netherlands, in Europe, 95% of doctors, neurologists, would order an EEG after a first seizure. And if that EEG and the MR was normal, half would order another test, another EEG. Now, is this necessary? That's a question. What is the role of EEG? Now, it is true that if we see epileptiform discharges, whether generalised or focal, that will support the clinical diagnosis of an epileptic seizure and perhaps help us guide us to the type of seizure. But of course, we know that the sensitivity of EEG is not so good. And in isolation, we will not use EEG to diagnose epilepsy. And most importantly, EEG is terribly misinterpreted. And so if I had a choice between somebody having bad EEG or no EEG, they're safer to have no test, no EEG. Now back to real data. What about the timing of EEG? There are several studies, including Mark King's from Melbourne, that suggest that, we must hurry and get the EEG in the first 24 hours because we'll get much more information. But these patients, actually nearly half of them had prior seizures, so actually still had epilepsy, so it's a bit flawed. Our own data shows that patients who have an EEG within 24 hours, the likelihood of picking up epileptiform abnormalities is 21%, and it's not much different if you get the EEG later. So my own data shows that you're not necessarily in a big hurry to get EEG, and there are resource and cost issues regarding trying to get early EEG. Now, what about the EEG findings? Well, this is our own data. If you have somebody who has an unprovoked seizure, their imaging and neurological examination is normal, and they have an EEG with epileptiform abnormalities, it is true that their seizure recurrence rate is increased. It's increased by about 16%. The green line, no EEG abnormalities, idiopathic. The blue line, EEG positive, idiopathic. So that is true. However, the 18% difference is not such a big deal, and in most patients it did not alter clinical decision not to start treatment. So again, this is not a big deal. So do all first seizure patients need an EEG? It's not needed. And just by the way, I'll go back to the previous slide. If you have somebody who's had a previous stroke or a scar on the brain from head injury or an image showing brain tumour, EEG does not add any more than the imaging finding to the likelihood of recurrence. And so in our own patients with 253 with a remote symptomatic cause, an old stroke, an old head injury, the EEG did not add any predictive value to recurrence beyond the imaging findings. So you don't really need an EEG if there's a clear underlying cause. Patient had a stroke 6 months ago, presents with a seizure. Do they need an EEG to know? No. You reserve the EEG for those with first seizure without obvious cause, and there is no rush. Having said that, do I personally get an EEG with every first seizure? Because I can, yes, but in a resource-limited situation, that might cost a lot for the person. Now, do all seizure patients need an MRI scan? And I like this cartoon. We're very thorough at this airport. Off we go through the MR scanner. Well, what are the limitations of imaging? If you have made your strong clinical diagnosis of epileptic seizure, yes, imaging can help tell you what the possible cause is, but it does not diagnose epileptic seizure. Structural lesions are only meaningful in the correct clinical context. For example, this person, this imaging, you'll see the left temporal pole has a change in signal on flare. This is after a head injury. This person never had a seizure ever. So imaging does not tell us the person has a seizure. It's only a way of exploring possible causes. What is the cause of the seizure? What is the electroclinical syndrome? What is the prognosis? Imaging can help us. There's no doubt about that. But do you need CT, MR, or both? Now, in a very resource-rich situation, we can do an MR on everybody, but this is very costly, and is it worthwhile? What tends to happen in my department, somebody comes into emergency centre, they have an acute CT scan. Have they had a hemorrhage? Have they had a stroke? And then we come to the first seizure clinic. Then do I need to order MRI scan? This is a common thing. So we've looked at this. Now, in our own data, it is true whether on CT scan, MRI scan or both, if we identify an epileptogenic lesion, the likelihood of recurrence is increased by about 15%. So that does not necessarily mean the patient needs treatment, but we will warn our patients that their 2-year likelihood of having another seizure is about 2/3, 2 out of 3. But you will note from that curve that the recurrence is very, very much in the early part of the first few months. And so you might say, if you've had an old stroke and it's caused a seizure and you're now seen in the clinic 4 weeks later, your risk is already rapidly dropping. And in 3 months, it's down to very low. So time tells us whether somebody has a recurrent seizure far more than the imaging findings. Here is the thing that worries us most. We've done a CT scan, we've examined the patient, taken a history, they have no neurological findings. Are we going to miss a brain tumour that the CT missed? And here's an example of such a scary situation. The person actually has a left parietal lesion that was missed on CT. How common is this? Well, again, we've looked at this at almost 500 patients who had a normal CT and then an MR, and sure enough, 1 in 10 of them, we picked up an epileptogenic lesion, and almost all of those were benign. A little bit of gliosis, mesial temporal sclerosis, a subtle malformation of cortical development. Hardly any of them had a malignant brain tumour. And the reassuring thing is that of the 7 patients with a malignant brain tumour, 6 of 7 presented within the next few months with additional seizures. So the actual cause drives the likelihood of recurrence. And so if we wanted to think about cost, you would need to do 67 MRI scans to identify only 1 missed tumour, and that missed tumour person is going to present within the next 12 weeks with another seizure. So again, it's not critically cost effective. So do all first seizure patients need an MRI scan? The short answer is no. It does increase diagnostic yield, usually a benign lesion when the CT is negative, and so that is of some help, but not dramatic. Waiting and seeing if a recurrent seizure is far more powerful in predicting prognosis. Now, shall we diagnose and should we be diagnosing epilepsy after a first seizure? Now, this is a danger zone. We know that we have unprovoked first seizure, remote symptomatic, an old stroke, perhaps dysplasia, an old head trauma, or idiopathic. And then we have acute symptomatic encephalitis, bleeding, trauma, and acute symptomatic alcohol, metabolic other. These are the recurrence rates for these 4 groups. If you have an acute symptomatic, the green, whoops, I can't use the pointer very well, the lowest recurrence rate is if you have a systemic cause, toxic, metabolic, lowest recurrence. The second lowest recurrence rate, long term, is acute symptomatic with a new lesion, like a stroke or encephalitis. The third and higher recurrence rate is any unprovoked seizure, idiopathic, but especially if you've got a remote symptomatic lesion. So this we know. But you'll notice all of them, the recurrence, if a recurrence occurs, it's mainly within the first 6 months. Does etiology drive? The answer is if you've got a tumour or mass lesion, the likelihood of having recurrence is much higher than if you've had an old head injury. And it's notable that an old gliosis head injury is no more likely to recur than somebody who's got no imaging findings. So etiology also drives the recurrence rate. Now, As you know, the practical definition of epilepsy that came out over 10 years ago says that you can diagnose epilepsy after one unprovoked seizure, and the likelihood of a risk equates to that of somebody who's had epilepsy, that is 2 unprovoked seizures. Over the next 10-year period, they estimated a 60% risk of 2 unprovoked seizures over the next 10 years. Well, in fact, the problem with that is difficulty. These are our own patients with epilepsy. Now, this is a graph showing people who've had 1 seizure and then at a distance, months later, another seizure. So all of us agree they have epilepsy, 2 unprovoked seizure events. Now, their likelihood of having a third seizure is 61% at 2 years, not 10 years. In fact, their risk of having a seizure at 10 years is 85%. So unfortunately, the working diagnosis of 60% at 10 years is underestimating the recurrence rate of people with real epilepsy. So in other words, the task force of opinion of a risk at 10 years of 60% or more is actually a too low a bar, and House's data reflects their own data that in fact if you have epilepsy, that is 2 unprovoked seizure events, the risk is much higher than this low bar that the task force put. The other difficulty is epilepsy is supposed to be an enduring predisposition to seizures, okay? Now here's our risk of recurrence in all 4 of these groups. Notice the risk is incredibly time dependent. At 1 month, the likelihood of you having, let's say the person comes to the clinic 1 month after their first seizure, their chance of having a second seizure has already dropped almost a third. In fact, at 6 months, it's fallen. The majority, the likelihood of having a seizure in all of these groups has dropped to far less than 50%. And so we've looked at idiopathic with EEG positive, idiopathic with EEG negative, and remote symptomatic, that with a lesion with unprovoked seizures. And sure enough, the data-informed threshold indicates that after 12 weeks of seizure freedom, all of these groups, by definition, do not have epilepsy. So sometimes it's better for our patients not to see us early because they won't have medicines started which are costly and with potential side effects than to see us early and us make an early diagnosis. This is the most important point I hope you will get. So, can we make a diagnosis of epilepsy after first seizure? Certainly in a remote symptomatic with a tumour lesion, I think we can, but in the other groups, no, we can't. Now, what about early treatment? Is there a reason for us to get on with treating first seizure early because the next seizure is going to be terrible and the person might die? You know, we're maybe rescuing this person by starting medicine. And in fact, the task force said it's especially useful to prevent unnecessary injuries and consequences of recurrent seizures, including social consequences. Although the social consequences of having an early diagnosis of epilepsy and the financial consequences of being started on anti-seizure medicines unnecessarily are very severe as well. So, why not treat after a first seizure? Well, firstly, the clinical diagnosis might be wrong. And first seizure, only half will occur at 2 years, okay? The other reason we don't want to start treatment is because anti-seizure medicines have side effects, including costs, and there's limitations. The person now has a label of epilepsy which stigmatizes them. And the other thing is the treatment really going to make a difference? Which brings me to the UK and Tony Marson and the MESS study. The MESS study was a multi-centre epilepsy and single seizure study. They looked at unprovoked seizures and randomised to immediate treatment and treatment after the second unprovoked seizure event. And the short answer is there was a slight reduction in the seizure recurrence rate of those that had immediate treatment, but the number you needed to treat to prevent the recurrence in a single person was 14. You needed to treat 14 people unnecessarily to help one person have a recurrence. Not such great odds. And more importantly, those who had delayed treatment to when they had the second unprovoked seizure, their prognosis was no different to those who had the immediate treatment. The only difference in the two groups in terms of mortality and serious complications was those who started early treatment suffered more side effects from their medicines. So the conclusion strongly is early treatment does not alter prognosis. And our own data reflects this too. The two top lines, the red and the blue, are people with remote symptomatic seizures, treated and non-treated. You'll notice it makes no difference to their prognosis, and the same with the idiopathic group. So does early treatment prevent morbidity and mortality? No, this is a fiction. Treatment reduces the short-term recurrence rate, but makes no difference to long-term prognosis. Short-term gains offset by side effects. Now, do we treat a first unprovoked seizure ever? Do you and I? Of course we do. We individualise decisions. For example, I see a 45-year-old man, he's had his first unprovoked seizure, it causes a mechanical fall and serious injury, he's on warfarin. I don't care whether his risk is 20%, it's scary. And I discuss as a partner with the patient what we will do. Even a small risk may not be acceptable. So I'm not promoting that you should not treat first seizure. I'm promoting that as a partner with the patient we make a careful decision. Now the final point that I wanted to drill down on is, what about old people like me? You know, hey, I'm old and crumbly, I've had a first seizure. Maybe my recurrence rate is much higher than young people like Chien. And the rest of you. And maybe because I have a seizure, I'm going to have much more injury. So old people, I'm going to be more likely to treat. Now, is this a fact or fiction? And there are many articles, special considerations, epilepsy in later life. And we've actually looked at our own data in young and old, and we've used 65 years as a cutoff, although, as you know, 55 is sometimes old, and my children, they think you're 35-year-old. So it's variable. The notable thing is that thinking about age alone, there is a slightly significantly higher incidence of seizure recurrence at 2 years. It's 6%. It's 54% recurrence less than 65, 60% greater than. So that's not so great a change, really, is it? And in fact, on multivariable analysis, age is not a risk factor of itself for recurrent seizures, okay? And if you're old and had an old stroke, you're likely to have a seizure recurrence just the same as a 35-year-old who's had a stroke. So it's the etiology, not age, that drives prognosis. And the other interesting thing that we found in our study is this: injury after a seizure. Those over 65 and less than 65. With the initial seizure, you'll notice injury in the older people was 1 in 10. Injury in the young was 1 in 4. That shouldn't surprise you. Young people with strong muscles are going to dislocate their shoulder, dislocate their jaw. Major convulsive movements will traumatize them. With the second seizure, the likelihood of an older person sustaining an injury is less than 1 in 20, and it's 3 times of that for the young. So if we're thinking about, injury, the elderly are not a special group, except they're less likely to be injured by seizures. So elderly people, it's only a small risk of increased further seizures, and it's not due to age alone, it's due to the etiology, and older patients are far less likely to sustain injury. So here's my last slide. Summary. Is a first seizure a clinical diagnosis? Yes. Convulsive syncope is far more common than a first unprovoked seizure, and many first seizure patients with a history have had prior seizures, so you can make the diagnosis of epilepsy. Do multiple seizures as an unprovoked cluster increase the likelihood of recurrence? No. Do all patients need an EEG? As much as I'd like to say yes, no, they don't. Do all patients need a brain MRI scan? Definitely not, unless you're in a rich country. Should epilepsy be diagnosed after first ever seizure? Mostly no. Does early epilepsy diagnosis and starting treatment reduce morbidity and mortality? Definitely not. And do old people like me need special treatment? Oh yeah, I like that, but not treatment with anti-seizure medicines. So that's where I'll stop. Thank you.
Thank you, and thank you for all the audience for joining the webinar. And thanks to John's comprehensive introduction of the procedure, evaluation, and management. And let me remind you, please put your question into our Q&A box. And we will discuss all of the questions after 3 videos. So we will move to the next video, and it will be released by our professor, Bejoy Thomas from India. I think Professor Thomas is a very experienced pediatric neurologist, especially neuroimaging. So his speech will talking about modern imaging for epilepsy as a very practical guideline. So please enjoy the videos.
Respected Chairperson, and good morning to everybody. I would like to thank Dr. Kwan for educating us about EEG, because I'll be a little more educated in the next epilepsy meeting. So we will talk in the next 30 minutes about modern imaging in epilepsy. This is a practical guide, and these are my conflicts, and this imaging in intractable epilepsy. When we talk about imaging in intractable epilepsy, we are basically today talking about how to evaluate these patients for epilepsy surgery. So to diagnose, categorize, and select patients for therapeutic planning, including potential surgery. So even in the era of epileptic networks, we know that demonstrating a substrate on an MR image is the best predictor for a best surgical outcome. The imaging has to be always correlated with the clinical and electrophysiological data, and a concordance is that what the epileptologist is looking for. And we need to always have a multidisciplinary approach and epilepsy imaging conference to decide about the patient's outcome. So we are concerned about the epileptogenic zone, and the basically, even when we think of epilepsy as a network disease, we are looking at the atrial onset zone and the epileptogenic zone, and for the potential removal of substrate before actually it is forming a wider network of intractable epilepsy. So today we are going to discuss about 10 practical tips of epilepsy imaging. And the first one is always is the question whether to use which the field strength is to be used. ILA approves both 1.5 Tesla as well as 3 Tesla, but it is always better to use the higher Tesla, higher magnetic field, because the signal will be higher in the higher signal and you can actually do a lot of things. So this is a paper from 1995. We have actually seen how MR quality has evolved over the years. In 1995, they were talking about new technology development in epilepsy imaging, and this is the case of a multiple sclerosis patient, and you can see how poor the resolution was back then. Now coming to that, now we can actually see a very high resolution, can make very high resolution coronal images of the brain, the axial images of the brain, and multimodal imaging is possible with MR, and this is what, sorry, I'll use the laser pointer. So you can see the very high resolution cross-section of the hippocampus. We will discuss about this in a little while from now. So since everybody's epilepsy protocol was different, ILA came up with this standard protocol. The harness protocol is 2018, and we should do at least the one 3D volume T1 and a 3D volume flare in isotropic resolution, and a high resolution T2 perpendicular to the long axis of the hippocampus, and this is the minimum sequence required. And why this is because we can actually reformat these 3D sequences in multiple planes and look at these images and actually hunt for a very small lesion like focal cortical dysplasia. So then the problem is this has to be optimized both for children and for children and adult, and for your scanner, because if you just copy the parameters of one scanner, may not work in another scanner. So we found that in addition to the harness protocols, certain other protocols which are very, very useful. I will talk about ASL and SWI today. So when we come to focal cortical dysplasias, this 2011 ILA classification has actually formed the basis of differentiating it into several subtypes. But with this, we know that with the 2022 classification, some of these substrates are actually in question, especially the type 2, and the type 1 A and B and C, as well as the type 3 subtypes. So this is the new classification they propose. This is also a work in progress because a lot of things are not yet clear. So the basic difference between 2011 and 22 is that they have actually given importance to immunohistochemical staining and a phenotype-genotype correlation. And now a layered classification is a must for a pathological the examination of any surgical specimen. In addition, mild malformation of cortical development and mild malformation of cortical development with oligodendroglial hyperplasia, popularly known as MOGI, is also added in addition to no definite FCD on histopathology. And as I previously mentioned, this is a multi-layered approach. This is a pathologist report, but you can see in the layer 3, neuroimaging is given a bit of importance now. And this is, we have to describe that even in the pathology report, what we actually saw on a neuroimaging. So this is what the pathologists see when we are actually seeing the cortical dysplasias. This is the control. You can see the proper organization of the cortex on a Nguyen stain, and it is a completely disorganized in the case of a cortical dysplasia. And based on whether you are seeing balloon cell, the dysmorphic neurons, it will add to type 2A, and then a balloon cell is adding to the type 2B of the Taylor subtypes of dysplasias. So everybody is fond of this finding the Taylor type 2B. We can actually easily detect most of the time because of the transmantle sign. There is a thickening of the cortex, and it's actually in the depth. You can see that the poor gray white differentiation most of the time on FLAIR images. It can be a little brighter also. And you have to specifically hunt for this, and if you see this, we are very happy. And if it is actually correlating with your EEG findings, I think it is very easy to remove this for the surgeon. And this is we have to scroll multiple images, multiplanar, so that we will not miss this. And especially when we are talking about type 1 A as well as the type 1 FCDs as well as the type 2As, it is not that easy compared to type 2B. So the 2022 classification again emphasized on the depth of sulcus dysplasia. These are a little tricky. If you actually casually scroll through your images, you can actually miss it. So for example, in this case, the surface, there's the deep sulcus in the superior frontal sulcus, and the depth of the sulcus, the gray-white differentiation is changed. The gray matter is thickened. And how you can actually identify it is very easily. For example, if you run an ASL sequence, non-injectable contrast perfusion technique, you can see some hypoperfusion in the right frontal lobe. Then you have to clearly look for any subtle lesion out there. This is what you see in the immunohistochemical staining, and this is because in the depth of the sulcus, more towards the superior part, you will see more of dysmorphic neurons in this, which are actually stained, labeled by non-phosphorylated neurofilament H specific antibodies, and slightly lower down, especially in the mantle, you see more of vitaminin positive balloon cells. So this is really important, and it's actually emphasized in the new classification. And there are ultra-high field specific findings also describe that the intracortical black lines signal in type 2B dysplasias. This is only described with 7T. We have tried in 3T with very high resolution. We cannot actually see this. It's basically because of probably more of iron deposition or more hypoxic changes there because of the deoxyhemoglobin there. So it is only picked up in a 7 Tesla. And coming to the eternal question, whether this is a type 3A dysplasia or it's hippocampal sclerosis with neocortical secondary changes. This is really difficult, and we will discuss some of our research on this. And this is, for example, the amygdala is bulky and there is a hippocampal sclerosis associated. So the real question is it FCD type 3A, or is it a dual pathology, or is a secondary finding to hippocampal sclerosis? Even though it is not easy, again you can see the neocortical changes when it is there associated with hippocampal sclerosis. Your MR radiologist should report it as a neocortical change, not essentially as probably associated dysplasia, because dysplasia also can be associated. So this is again in the ASL, you can see profound hypoperfusion in the neocortex as well as the medial temporal lobe, and this is one of the signs which says that the neocortex is really important. And we've actually done a small study as a DM thesis, and we found that the ASL is the one predictor which says that the neocortical thing could be more towards a dysplastic change. And this is again, we are actually presenting in American Society of Neuroradiology in May, and we found that we cannot actually differentiate whether this is a type 3A dysplasia or a secondary neocortical abnormality on hippocampal sclerosis based only on MR imaging. And the best predictor is ASL. And again, but there are clinical differences. The clinical differences are, if you're seeing these neocortical changes, especially with ASL abnormality, they tend to, the epilepsy origin will be earlier, and their neocortical origin of epilepsy is also more often seen if you are seeing these neocortical changes. But the surgical outcome, especially when you are doing an anterior temporal lobectomy with amygdala hippocambectomy, the surgical outcome is no difference between these two things. And in a series of 6,000 patients, and of the 251 patients with the these abnormalities of hippocampal sclerosis, of which more than 107 patients being with the neocortical abnormalities on MR, we saw only 6 patients with abnormal dysplasia on histopathology. So it is more rare than we actually think. The type 3 dysplasia, this is a controversy in type 3A dysplasias, which is again highlighted in the new classification. I'm sure that is actually come up in the next classification as well. So then we have new advanced sequences like synthetic MRI, where you can actually map the myelin. We can actually map the myelin. This is a myelin map from synthetic MRI, one sequence which is actually giving you multiple parameters. And this is again, we have published very recently in January 13 in Neuroradiology. You can see that the anterior temporal changes, the myelin pallor which is seen in histopathology, can be predicted by this myelin map. You can see compared to the other side, there is significant myelin pallor. This is what you are actually seeing in as a poor gray-white differentiation, not essentially a neuronal loss or not essentially a neuronal disorganization. So we cannot actually infer more than we actually there from an MR appearance, even though the radiologists are very, very enthusiastic in reporting more on this thing. This is the same sequence with the myelin map. You can actually have multiple contrasts. So the way we image in epilepsy patients may be very different 2 or 3 years from now, because we can actually run one sequence and get all these contrasts. For example, we can have a PSIR sequence from the same sequence we have actually done. You can see this, the subcortical nodular heterotopias. So one sequence caters for everything, including a myelin map. So we used to report this as the focal cortical dysplasia, very, very difficult sometimes, because some of them will be very subtle, some of them will mimic a dysplasia. And in the PET imaging also you can see hypometabolism there. We reported this as a dysplasia, but in pathology, this is not actually a dysplastic lesion which is seen. Lot of oligodendroglial cells, it's OLIC2 positive, many cells, and if they are more than 2,200 cells per millimeter square, we now call it as MOGI, and mild malformation of cortical development. We are again conducting, we have actually submitted a paper which says that if it is actually more than 2,200 cells per, OLIC positive cells per millimeter square, that is more suggestive of MOGI, but it cannot be differentiated from an oligodendroglioma. Oligodendrogliomas also will have this many number of cells, but it is entirely different from a cortical dysplasia, type 2 cortical dysplasia. They will never show oligodendroglials of this high proliferation. Now we know that there is a genetic basis of this. This is an SLC35A2 and the gene mutation which is actually producing it. And we can actually differentiate between the mTOR pathway, MAP kinase pathway abnormalities, which is seen in focal cortical dysplasias, especially the type 2 focal cortical dysplasias, and SLC35A2 mutations. But there is significant mosaicism. We have to actually do the genetic testing in the resected samples as well. So these are different conditions, their prognosis may be different, but radiologically they are actually mimicking each other. Very difficult to differentiate in the current scenario. I hope that there will be more possibilities coming up in the coming years. Second, very important rule, or actually the practical guide, is that neurosonography is very versatile. Once the skull is removed, ultrasound becomes an excellent modality to look at the brain. So in an emerging world, especially, we cannot actually afford, most of us cannot actually afford a peroperative MRI. And even if you have a peroperative MRI, the surgeon would not like to shift the patient in and out of an MRI scanner because it's very, very cumbersome. But if you put an ultrasound probe, very high resolution ultrasound probe, you can actually see this cortical dysplasia in a much higher resolution, and the surgeon can resect under guidance, which can be actually synced to their stereotactic system. It is very easy to do this, and most neurosurgeons are now coming, shifting from a peroperative ultrasound than a peroperative MR, which is really difficult. And it also can cater for the brain shift which is happening after this thing. So it can be even readjusted to the brain shift, and it can be resected, syncing to that. The probe can be synced to that stereotactic system, and it's really important. I don't know why in India people are not using this quite often, because it is very difficult to hunt for a depth of the sulcus dysplasia for a surgeon. So the neurologist will also say that they have actually missed the lesion, but it is not really easy. But if you use these small simple techniques, which are very, very, very cheap, cost effective compared to our peroperative MR installation, I think we can do that. We have to have a very high resolution probe for this, and a high resolution and ultrasound system for that. So dysplasias are chameleons. When you are looking at childhood dysplasias, they are chameleons. They can disappear, they can hide, because if you won't see it in a 2-month scan, and they will appear in an 11-month scan. So depending on the myelination, or they are very obvious on a 2-month scan sometimes, but it is actually becoming normal in a later scan, and it's also very, very important. So third thing is that not everything that looks like a dysplasia is a dysplasia. The radiologist will tend to report it as a dysplasia. For example, this case, poor gravid differentiation. This is reported initially as a dysplasia with the post-ictal changes, and because there is perfusion changes there. But if you see, this is in April, and you see by July, again, this thing, the lesion has largely disappeared. The perfusion has become normal. This appearance can come in Mela's disease. It can also come in this autoimmune encephalitis. This turned out to be an autoimmune encephalitis. Not that all autoimmune encephalitis, you will see only changes in the hippocampus and the temporal lobe. So this turned out to be an autoimmune encephalitis. So it is very, very important for neurologists to understand that even when your MR report is different, you have to think twice. It has to be always correlated with the clinical history. Know your sequence as well, when to use what. The neurologists, even radiologists, general radiologists are not aware of that. And if we are not doing an epilepsy protocol to detect a substrate, it is all the likely that 50% of the time you will actually miss the lesion. It is better to toss a coin than actually looking at the MR and diagnose. So you have to have an epilepsy protocol. Even then, you should have a very high resolution epilepsy protocol, especially on a 3 Tesla. This is the internal anatomy of the hippocampus. I will not go into the details of this. Another very important thing, you have to narrow your the flare sequences and look and hunt for the focal cortical dysplasias. The one caveat here is that because the hippocampus, the insula, as well as the cingulate gyrus, they are paleoarchicortices, because they will be brighter on normal flare as well, but you have to always compare. For example, in the right hippocampus is much brighter compared to the normally bright hippocampus, but the neocortex, you see, the neocortex is not that bright. So you cannot actually say that just because this is bright, this is abnormal. It also depends on the number of pyramidal cells in that cortex. So this is what it is, which I've talked about, and you can do the T2 relaximetry. Nowadays we are not doing is with synthetic MRI, we can actually get the T2 relaxation values directly. Again, one sequence fits for all. So and the internal architecture of the hippocampus can be very well delineated. Of late, there is a lot of interest on this because this subfield sclerosis can be diagnosed with the MRI. That's what the people are claiming. We can see the new and stain. It is actually see the CA4 and the dentate gyrus there, and then the CA3, CA2. CA1, CA1, then the subiculum and the parahippocampal gyrus. So in addition, you can see the SRLM here, and you can see the stratum oriens and the pyramidals layer, that the hippocampal fissure remnants is there, and a lot more than actually can be seen. So this is what I'm talking about. This is recently there is an increased interest on subfield scanning, for example, because the type 1 hippocampal sclerosis has got a better outcome in many ways after surgery. So there are attempts, and for example, this is the normal cases is that you can see that both the entire part of the hippocampus is abnormal, especially the CA1 as well as the CA4, the dentate gyrus at the hilum region, and this is a type 1 hippocampal sclerosis. There are several reports on that. And recently, there is an AJNR paper which has come very recently, published in February. And you can see that they have actually looked at these subfields, and they have actually described whether there's a specific the atrophy of these subfields, whether we can actually predict the subclassification of hippocampal. We know that how the hippocampus circuitaries are there for epilepsy genesis, temporoharmonic pathways and the trisynaptic circuits, and it's really important to differentiate these subtypes. And then the mosifiber sprouting and all. And then this is a classification, ILA classification. They claim that they can actually differentiate because you can see that the tapering of the CA1 to CA3 can be lost if there is actually a type 1 sclerosis, and depending on these subfields, you cannot differentiate. We have done a study from after it is published in AJNR. We thought whether what they are telling, this was a review, but is there any enough evidence to say that it is actually true? We have, this is again, many cases it can be seen, but we analyze, there is a high correlation, kappa correlation, good inter-rater observer agreement between these subtypes, but the problem is that there is poor correlation with histopathology. So histopathology, what we are seeing in MR as atrophy and hyperintensity is gliosis and myelin loss, not essentially a neuronal loss. The hippocampal sclerosis is diagnosed. We forgot that there is something called type 0 hippocampal sclerosis in ILE classification, where there is no neuronal loss. It's only hippocampal gliosis. So you cannot differentiate. The correlation with histopathology is extremely not good. So we are actually publishing, again, presenting in ASNR, accepted as a paper, but we are trying to publish this also because what we actually infer, radiologists are overcalling things. So it is not really corresponding to what the pathologists are saying. There can be dual pathologies, double pathologies. We talked a lot about this, and this is, for example, the calcification in hippocampal sclerosis. This is because of the cystic circle cyst in our part of the world. This is also common. Then this is a temporal lobe epilepsy. When we see another lesion there in the frontal lobe. This is a cavernous malformation. Then the question is whether to remove, which of them to be removed first, or all of them to be removed simultaneously. These are real difficult questions to answer, and it is always discussed in an epilepsy meeting. ASL, I would like to talk because it's a very simple sequence. You don't have to inject gadolinium. You can actually run it any number of times. It's especially useful in pediatric epilepsy. You can see this on, it is your friend, but it can have many artifacts, and if you see this casually, the flare, you see nothing, but in the ASL you see there is an occipital hypoperfusion, which is more corresponding to a SPECT imaging than a PET imaging because it's more perfusion, but there are differences I will describe. So this, you see this, when you narrow the window, you see the gliosis out there, and this was removed. And this is another case on a casual look, again looking normal, but you see in the frontal operculum there is a small hyperintensity. This can be mistakenly reported as a focal cortical dysplasia, but we looked at the previous image done from elsewhere, it was normal, and the recent flurry of seizures, this again turned out to be an autoimmune encephalitis. And this is the interictal PET. You see the hypometabolism there. This is in the ictal ASL. Patient had a seizure just before the scan. You can see in the same area there is hyperperfusion, and which says that this is actually the substrate is in the right, exactly on that side. And this is the caveat from SPECT imaging. We are fond of this Syscom imaging, even though it is going out of fashion because of if we cannot actually inject the ligands so fast. And this is what happens, hippocampal sclerosis. You can see this ictal phase, there is a hyperperfusion there. But in this case, but whether this is concordant, we are not really sure. This, the hemodynamic response function and the the perfusion actually changes with the electrical activity. If there is a spread of the electrical activity from the anterior part of the hippocampus, the posterior part of the hippocampus, you will see this hyperperfusion in the posterior part. It may not actually correspond to the site of origin of epilepsy. So this is one caveat you should be always remembering. You can see this case, you can see there is a hypoperfusion of the right parietal region, superior parietal region, and the same area you can see hypometabolism in PET imaging, and many times there are several reports saying that ASL and PET, and it's really important as the ASL is called a poor man's PET, because you can, if you are doing amino acid PET, you can avoid an FDG PET, you can do an ASL and then go for an amino acid PET. That's really important. This is a case, again, a large dysplastic lesion involving the right hemisphere, and here again you can see that based on whether it's an ictal space or interictal space, interictal space, you can see there can be hyperperfusion or hypoperfusion in the same image. So it is a little tricky to interpret that, but it is really very, very useful as a sequence. When you see nothing, you have to look for very hard. For example, in this case, very, very difficult to see. This is a cis imaging. That's what you have to improvise on table. You have to look at the images. Radiologists should actually screen these images when it's being done. We have done the cis imaging. We have seen a small encephalocele there, and this is meningoencephalocele, which can be missed if it's a 2 millimeter or 3 millimeter section scans, and if you can pick up, you can actually save the patient. Again, subtle lesions, hypothalamic hamartomas, you should always look at the tuber cinereum, and you should also see that gyrosectus, focal cortical dysplasias. These are areas where these are our blind areas. You should always look. And be prepared for surprises. Many cases you see these long-term epilepsy-associated tumors like this ganglioglioma, and then the DNET, the classical flare hyperintense sign. But when there are lesions like this, very subtle, like small few cystic changes in the parahippocampal gyrus, cannot actually ignore them. They are actually corresponding, and this turned out to be plenty. So now it is very difficult for us to differentiate between ganglioglioma and a polymorphous low-grade neuroepithelial tumor of the young, and because plenty is a neuronal tumor and a ganglioglioma is a glioneuronal tumor, and it is really difficult for us to differentiate in many cases. So functional mapping is important, and this is especially when you are actually contemplating an epilepsy surgery in an eloquent area, and the easiest way to do is a functional epilepsy, the epilepsy imaging, and mostly we are asked to do the language mapping, and we can actually lateralize the language. The problem is that even though there are reports which that there is very good concordance with your WADA test, but you have to remember always that WADA is a lesional test and its fMRI is an activational test. They are entirely different, and you should interpret in the correct context. Especially now we are actually looking at, we have actually published the first paper on resting state fMRI, and because especially in children you can actually see these language networks, and it is slightly more difficult to analyze, but there are now the newer softwares we can actually analyze on the go is also coming up. So I'm sure that the resting state networks analysis, again, it will be useful for epilepsy network analysis. And then we look at the DTI sequence to see that these are research papers, not really possible in the routine clinical practice, and the diffusion tensor imaging, which is helping us to map these the maze loop and predict the surgical outcome of the visual outcome in temporal lobe surgeries. But when not very sophisticated things, for example, an SWA sequence, high resolution SWA sequence, you can see this optic radiation very well because myelin is diamagnetic. You can see the myelin there, and you can see the maze loop out there. So if you look at these simple sequences, you can get an idea how far this maze loop is, the anterior part of the anterior extent of the malleus nerve piece from the temporal pole. You can actually tell the surgeon that whether you can resect that 4.5 or 5.5 centimeters. So these simple things which are really useful, but never, really didn't get the attention in literature for epilepsy surgery is this. In the same time, you can see that you should look as a radiologist, your eyes should be sharp, and you are actually seeing a small hypo-intense area here, which is bright on a face imaging. This is a 3 Tesla. 3 Tesla is a right-handed system, and if you see the dark signal there and the bright signal there, there is calcium, and you should look at the flare. That's the gliosis there again, a gliotic scar surrounding a calcified cysticercus. So it should not be missed. So these are small things also can be picked up. Sometimes we have to we are not sure about that clinical significance of it, but the radiologist should always report it, and the pathologist even is in the layer 3, they are actually including our reports, and we are happy about that. So epilepsy imaging is always a teamwork. It is not that the radiologists and the neurologists are working in isolation, in silos, but we are always discussing it, and we are actually correcting our reports. Many times our first reports are wrong in the sense that the context may not be really wrong, but in the context of the patient's surgical outcome or a surgical decision, and we should not actually take be very egoistic and telling that we are always right, but we should many times, and also sometimes we will actually pick up lesions, and the neurologist will have a second look on the EEG, or they can go for other advanced EEG techniques. So this is how we do. This is not a simple paradigm as we think, but many times in a resource limited conditions like ours, we have to actually reserve advanced imaging as well as PET for select patients, and also the stereo EEG. It's not easy to do, and it is also very expensive to do. So we have to actually get the maximum out of what we have actually. That's why we have to improvise our techniques and do further imaging properly. So the 11th clue is that the 11th rule, which I also would like to say, is that none of these 10 rules or 10 tips which I have given may not be applicable in the next coming years, because I've told about one single sequence of synthetic MRI which is going to replace all these harness protocol. We don't know in sooner, but the AI is coming in the field that the radiologist may not have to look very carefully. This is a paper which I published many years back at the start of the AI. This thing now they have a lot of softwares which are available. The problem is that the sensitivity is very good, the specificity may not be very good. The radiologist is bombarded with this AI software telling that this is the FCD, this is FCD, this is FCD, and the radiologist who is actually, this is, how will you say that it is not there? So there are the medical legal problems are also there. The radiologist is always biased when the machine is throwing out something that is an FCD. So it is not that easy as you think. So the AI is coming, but the radiologist will always be there. As long as pathologists are there, they are actually changing their guidelines, their classification. As we are thankful to ILE, they are also changing their classification. So retraining these AI algorithms will be difficult. So the radiologist will be always there. And with that, the network as a disease, it is also coming. So we are looking at substrate as the epileptic focus may also change. Everything we are actually telling that 10 years down the line, my talk will be obsolete, I'm very sure. And thank you very much for your kind attention.
Thank you, Professor Bejoy Thomas, on a very exciting, interesting talk on the imaging for epilepsy practical guide. Our next talks will be by Professor Gagandeep Singh, who most people will know him well. He is the chair of the Education Council in the ILAE, and he's going to share with us how to improve the quality and availability of epilepsy training and education in our regions. Let's listen to Professor Gagandeep.
Thank you, Professor Lim. I'm extremely grateful to the chairs and the members of the Scientific Organizing Committee for allotting this talk to me, because I think it's been a incredibly great learning experience, and a very humbling one too. And the talk is all about improving the quality, which means not just the quality, the reach of epilepsy education in the Asian Oceanian region. And ladies and gentlemen, I'd like to begin with this quote from this paper in the 1960s. Louis Al-Jalek was a Scandinavian psychiatrist, and however she chose to become a GP and work most of her life in Africa. She had a great passion for epilepsy, and she initiated an epilepsy clinic in Mahenge in Tanzania in the 1960s. And the epilepsy clinic runs strong even today. And quote unquote, in this introduction to this paper, to be sure, the patients did not come to me for treatment of the illness, that's epilepsy, but rather on account of the resultant burns caused by falls into the fire. Which means two things to me. One, these people were having lots of seizures, hence they were not treated, untreated. So there was a huge treatment gap. And the second, it draws our attention to the dreadful consequences of epileptic seizures. Some more quotes, and this is Nelson Mandela, who said, education is the most powerful weapon you can use to change the world. And this he said in context of severe inequity in his country at that time, the apartheid. I want to borrow that phrase, borrow that quote for the International League Against Epilepsy. Education is the most powerful tool to bridge the epilepsy treatment gap. Ladies and gentlemen, a little more about the ILE and its vision. Helen is not here, but she often says the vision of the International League Against Epilepsy is to have a world where no person's life is limited by epilepsy. And if you look at these strategic goals, there is a strategic plan till 2030. Education is very strong amongst those strategic goals. The ILE believes that education can catalyze positive change, whether it is in terms of stigma mitigation, in terms of bridging the immense epilepsy diagnostic and treatment gaps, or in terms of improving epilepsy outcomes. And the ILE believes that this, of course, cannot be done with textbooks and classrooms. So we need to go beyond that. And that's what we are going to look at today. Many of these slides are borrowed from Professor Dunne, as also I had contributions by Professor Chen, Dr. C.T. Tan, and others, and Dr. Lim also. So this is the Asian Oceanian region, and that's the geography. And these are the member countries, and you can see there are 21 member countries or chapters in the Asian Oceanian region. And whenever we try to look at, implementation, how we can implement better education policies, we need to do a situation analysis. And this is the situation analysis. This information resource from the WHO clearly shows the stark difference. Europe, 9 neurologists per 100,000 population. And Southeast Asia, it's a little old data, but I mean, it would have been updated by now, but Southeast Asia region, it's 0.3 per 100,000 people. So that's the difference like. And a string of papers by Professor Lim, our chair, and so many other of our colleagues on the status, in fact, this research, the research agenda for the Asian Oceanian region. This was done in 2015. So I think it needs to be updated. We need to get education in the research agenda, education research in the agenda as well. But it clearly shows the small number of neurologists with epilepsy training and fellowship. Again, this might be a little old by 5 years, but nevertheless cannot be much different. Another table from this very interesting set of papers, and you can see here that the Ys are yes, so that means those are the barriers, right? And you can see that many clinicians are actually interested in learning more about epilepsy, and especially when it comes to high-end epilepsy investigations or treatments such as stereo EEG, which was the focus of this particular paper. There are some clinicians who have good expertise also, right? But the major barriers are in funding and facilities. So there are health system barriers. So when it comes to high-end facilities for managing epilepsy, such as stereo EEG, you need to complement the development of expertise with health system changes, including funding and facilities. That's my take from this particular table. But ladies and gentlemen, the word of the care word of someone with epilepsy is not just the epileptologists. there are many more people involved in the care of people with epilepsy. You have primary care physicians, and in many parts of the world there are no primary care physicians, it's just a nurse who first sees someone with epilepsy, right? So you have community health workers, you have advocates, you have nurses, you have EEG technicians, you have neurologists, you have psychiatrists, everything. So education needs to include not just epileptologists or neurologists, needs to include the entire spectrum of people who are involved in the care of someone with epilepsy. And that's something we really need to keep in mind. If you go to the ILE website and go to the AO page, it's teeming with educational resources. I mean, there is such a huge fund of educational resources. You have this interesting set of videos. Manjari and Sarath made it, and you can see Manjari smiling here. And then this another interesting set of very short, succinct, crisp videos, not more than 10 minutes. Right, by the Taiwan Epilepsy Society, and this covers the entire spectrum of EEG. So and they're free on the YouTube, right? So you just have to go log in, and in 10 minutes you get to know non-epileptiform abnormalities. 10 minutes you get to know all about artifacts. I think this is a wonderful resource, right? And then these activities. So. All I can claim credit for is making the collage, but all of these have been possible because we stand on the shoulders of giants. Professor Dunne, Professor Chen, Lim, Professor C.T. Tan, so many others, Professor Satish Chandra, Dr. Mendiratta, so many others. And you can see in 2022, most of the activities were online, right? They were virtual. 23, there's a transition, and 2024, the transition is complete, right? And you have these wonderful courses. I try to put them in a map, and these are all the epilepsy courses organized in the AO region under the auspices of the ASEPA, different types, different locations, different courses. The ASEPA, we've just revised and we've discussed the nomenclature, whether these should be called as fellowships or training visits, so whatever we call them. And the black stars is the location where the trainees were located. And Professor Tan sent me an entire table and I put it on this map. I mean, I drew this map myself, so it might not be very accurate, right? But the black stars are where the trainees were located, and the red stars is where they trained, the centers of eminence in epilepsy, right? And BC means, BC is not before Christ, this is before COVID, because there was all of this stopped during COVID. As many as 72 over a period of, correct me, 30 years? Nearly 30 years, right? 25 years, right? So 72 people have been trained in different countries. So just look at this wonderful cross-country collaboration, right? And I'm quoting Dr. Tan, and he really took the effort of, ascertaining the long-term outcomes of the people who went for training. And just except for a couple, all of them are in their country of origin and they are practicing in the country of origin. And many of them, and probably there are some sitting here, are leaders in their own country, epilepsy leaders in their country, presidents of their national society, secretaries of their national society, and so on and so forth. And what I also found very gratifying is that many of the centers, particularly Cochin, Trivandrum, and Delhi, where people initially went overseas via the ASEPA for training, But now they are accepting trainees from other parts of the world. So that's absolutely fantastic. And that's the concept of training the trainers and how the chain is actually established. Again, from Derek, the ASEPA EEG examination, again, a shining example of what is being done in the region. There are two parts. There is a written and an oral, and you can see the curriculum. I mean, it's a busy slide. I don't want to, but it's the complete EEG spectrum, right? Wonderful. Okay, so switching gears, and from the AO region, we go to the ILE in general. And there are a number of educational activities happening in the ILE. You have the ILE schools, you have the once in 2 years congress alternating with the regional congresses such as this one. You have the VIREPA, which is a virtual academy, which is tutored. And there are a number of regional courses, and finally you have the ILE Academy. And the difference between ILE Academy and VIREPA is that VIREPA is tutored. It's online but tutored, but the ILE Academy is tutorless, right? So it's absolutely self-paced. There are 8 ILE schools, and these are listed here. Roughly about 425 attendees. Many people from Asia actually go to these schools. And then you have the ILE Academy. We have a session during lunchtime in Coral Hall, right? If I remember correctly. And we'd be discussing a little more about the ILE Academy in that session, and Helen would actually take you across one of the cases, just to give you an example. But I have to say a few things about the ILE Academy. One, it's online, right? You can log on to it. 2, it is self-paced. And self-paced means you can log in whenever you want, whenever you have the time. And then if you're tired or you are busy, you can log off and then rejoin at the same point whenever you have time, right? So it's at your own pace. And it's very structured. That's the other point. So the third point is that it's very structured. And when I say structured, it means that it's based on the ILE epileptology curriculum, which is a set of competencies and learning objectives divided into level 1, which is entry level, level 2, which is proficiency, more advanced, and level 3 is advanced proficiency. So at the end of level 1, there is a self-assessment exam. You pass the exam, you get a certificate, and this is for the interest of my younger colleagues. And then you sit for level 2. It roughly takes about, probably if you spend a couple of hours in a week, it will take you about a year or so to complete level 2. But once you're level 2 done, you are eligible for in-person training visits of up to 3 months, supported by the International League Against Epilepsy, for level 3, right? So level 3 is in person, but level 1 and 2 is online, right? So, and this is very interactive. It's not just a set of slides, right? Or a set of lectures or a set of videos, but it's really very interactive, right? Based on, some of them are based on adaptive learning, right? Where if a candidate is good, he's asked tougher questions. If a candidate is not good, he's asked simpler questions, right? That's how teachers used to do it in school, right? So that's the ILE Academy. And then primary care. So in many parts of the world, and Professor Dunne gave an excellent talk on first seizures, primary care physicians are the point of first contact for someone with epilepsy. And in parts of the world, they're the only point of contact. There are no neurologists, no specialists, right? So the ILE recognized this and commissioned a task force to develop a curriculum for primary care, epilepsy curriculum for primary care physicians. And this is the final product. But I'll just take a couple of minutes more, maybe 3 minutes more, some personal experience. And this is our study, which was a community-based trial of home-based care by community health workers versus clinic-based care, and that's the trial design. That's the trial design here. And these are the outcomes at the end of 2 years. The seizure outcomes or the epilepsy outcomes, and this is the adherence. Just look at the adherence. It's a bigger graph. And in these bars, the blue portions are the ones with good adherence, right? The orange ones, and adherence was based on pill counts done every month. They were provided medicines. At the end of the month, pills were counted. So the orange ones are the poor adherence due to missed doses, right? Underdosed. But there was also another portion, another part, or a group of people who actually overdosed themselves. They took more tablets, more anti-seizure medications than they were supposed to take. And small, but nevertheless they're there. You know, every bar has a green portion. And those are the people who overdosed themselves for a variety of reasons, including if their seizures were not controlled, they believed they could take in a couple of extra pills, or even if they had some intercurrent illness such as diarrhea or viral fever, and they thought that this was a panacea, the anti-seizure medication was a panacea for all kinds of illness, and they could pop in those pills, right? So that's also something we need to address, right? This is something which we never expected and never believed that can happen, but people can overdose themselves with anti-seizure medication. And this interesting case, 50-year-old woman, educated up to primary level, a mother of 3, she had generalized tonic-clonic seizures since the age of 14 years. Coincidentally, her father and son both had epilepsy, but she had never ever consulted a physician for epilepsy. However, when she had epilepsy, her parents told her to take the same medicine that her father was taking, right? And she took it all her life, right? And that was a combination of phenytoin and phenobarbital. And this was picked by our fellows in the community. I think some of them are sitting here, right? And it quickly snowballed. I couldn't believe it. And I thought this was a one-off case. But they quickly got 6 different people in the same community who were sharing anti-seizure medications. Sharing of, pain control medicines is well known, but sharing of anti-seizure medications is not known. So the reason why I brought up these cases is that no one size fits all. Every region is different, and every region you need to address local needs. So there is a global approach, but there have to be local needs. And in terms of primary care, the ILE is doing a lot. You have the pediatric epilepsy training courses, and I believe, Derek, you're doing the PET courses in Singapore. There have been previous PET courses in India and one more place I'm forgetting. Sorry. Right, Myanmar, right. You also have the ETAM, and our president, Professor Cross, was in Zimbabwe last week, and she did the first ETAM, which is the epilepsy in adult medicine training course, right? And that's based on the PET course, so it's training the trainers. So you train the trainers, and the trainers then do the course, right? And lastly, we have this interesting resource which is upcoming, should be there in about a month's time at the ILE Academy, which is the ILE Academy Primary Care course, which is based on 27, again, short, crisp modules. Professor Satish Chandra is one of the teachers there. And there is a pre-test, there is the module, there is a post-test, you can get feedback, and at the end of it, you get a certificate. So that's for the primary care physicians, and this is what is being done. So, ladies and gentlemen, what are my conclusions? I think we need to include education research in the AO research agenda. We need to have more cross-country. There are a number of good cross-country surveys, right? But we need to have more of those, and should include many more countries in the Southeast Asian region. And we probably need to make a database. We have so much in the Asian Ocean region. So we need to make a database of those educational resources. People in other, John, this is for you. People in other ILE regions also need to know the good work that is being done in the Asian Oceanian region. And they might like to borrow our courses. So I think that's extremely important. And lastly, we need to make primary care our agenda. And this is really going to be cost effective because you don't have to travel to do primary care education. All the local neurologists can do it in their cities, in their towns, wherever they are. They have an onus to educate all the primary care. That's it. Thank you so much.
Hi, everyone. Yes. Okay, Qin-Seang, it seems no question in our box, right?
Yes, but there are a lot of things that we can discuss, and while waiting for the questions, we can start some snowballing and discuss some of topics.
Yeah.
Well, one thing
yeah.
one thing that comes to mind instantly, it's as you all know, I've confessed I love EEG, and I look at an EEG and I look at it again and see different things and learn different things. It's like hearing Bejoy Thomas's imaging talk and Gagandeep's wonderful talk on education. It's a richer experience to hear it again. So thank you very much to Gagandeep and Bejoy. And we all agree, as my father said, we stop learning, we die. And so education is for us all, young and old.
Yeah. Of course.
Yes, education is very important.
Yeah. Thanks to John's and Qin-Xiang's leadership. So we will work hard on the continual educational in our region. Yeah. Oh, I think we have a question come out.
I can read it if you want.
Yes, yeah.
So the question is from Dr. Shah Jahan from Bangladesh. It's on can we plan for undergraduate medical education program to update the epilepsy curriculum? I think this question is for Gagandeep.
Sorry.
For undergraduate medical education program.
So that's something that really needs to be done for undergraduate. It's undergraduate medical education, right?
Correct.
Right. Yes.
Yes.
Yeah. So the primary care curriculum is one step towards the undergraduate education. At that time, I mean, I think it's extremely important, and it would be, I'd be very interested to know John's and Chen's view and Kheng-Seang's view on this. Is having increasing or thinking about what should medical students know about epilepsy, and that's extremely important. That's something that we have really not ventured into at this point of time, but this is something that we really need to think about because the undergraduate education forms the basis of what we are as doctors, and the amount of or the kind of epilepsy education that is imparted during the undergraduate years generally, I think, has a foundational effect and would be extremely important. In terms of, I think that's the first step, and then we need to look at what kind of grants and what kind of things can be done for the undergraduate people in their undergraduate years. But the first step is to, and there are a huge, I think there is a word directory of medical schools, and probably that's where we really need to begin with. I'm not sure. I think so. John, you have some thoughts on that?
Look, this is a very important topic for us all. Firstly, we all understand that undergraduates have an overwhelming ocean of different topics to cover, and everyone thinks that their topics are special. The other difficulty that we face is that despite the very importance of how we think and how we feel, i.e. neurology, medical students, and for that matter, young doctors, can have a phobia about neurology as being, oh, it's too complicated and it's too difficult. But as we all know, it's not so hard. And I keep explaining to people, I don't understand how my own brain works, let alone anyone else's. But that doesn't mean that we can't help patients who present with neurological problems. And after all, episodes of impairment of consciousness, everyone in clinical medicine has to face and help patients in this regard. So I think that we're in many ways up towards the top of the tree in terms of important neurological knowledge that undergraduates must feel comfortable with guidance and help. So I totally agree that this is a very important topic.
Yeah, thank you, Gagandeep and John. So thank you, John and Gagandeep, for emphasizing this and at the same time, we also want to promote the cost for primary care, as what Professor Gagandeep has mentioned. We should encourage our primary care team to join the course, which will be very useful, mainly because many of the patients in the district and the rural areas, they will see the primary care doctors first before seeing the neurologist. So Professor Gagandeep, there's another question. I think this is straightforward questions about how to apply for ILAE academic course, or how to register themselves, from Dr. Ati.
Right. Yeah. So it's very simple. You go to the ILE Academy website. There is a small fees. It's actually highly discounted for low and middle income countries. And you can then take level 1. You can do the level 4. Proficient in level 1, then you could actually do the level 1 exam. And after having cleared the level 1 exam, then you're eligible for level 2. Level 2 is takes a bit of a time. As I said, if you spend maybe a couple of hours in a week, you could complete level 2 in less than a year. But if you spend more time, you could probably do it quicker. I know of people who have done it in 6 months' time. And once you've done level 2, you can actually apply for an in-person level 3 fellowship. So there's an entire spectrum.
And coming back to the first seizures and related to educations, I can see that among the participants, many are juniors, and perhaps they would want to know how would John counsel a patient. Let's say if a patient come with first seizures with underlying lesions, for example, old stroke, how would you counsel them? Since you have explained so much about whether to start or not to start treatment, and in a case like this, how would you counsel the patients?
Look, one of the most important things is, and this is where we have an opportunity to build a relationship with patients and their family. The most important thing is, as I mentioned in the talk briefly, if a family member has witnessed one of their loved ones having a seizure, it's absolutely terrifying. The person may be frightened that their son or daughter or parent may be dying, and trying to allay that anxiety, indicating the self-limited nature of seizures and the fact that whilst feeling helpless, simple first aid is critically important. The patient's safety. Another counselling thing that's pivotally important is for patients who've had a recent seizure, whether they are started on treatment or not, being aware of the fact that dangerous activity like driving a motor vehicle or working at heights, or in fact bathing on their own, or very much so in, as Gagandeep mentioned, in Africa, and the same plays out in Timor-Leste. I've seen terrible burns from patients with seizures who've rolled onto the fire, which is in the house to keep the person warm. Back to the issue of understanding what a seizure is and its consequences. Then when it comes to recurrence, our goal is to inform patients in a way that's understandable and allow the person to be involved in the decision about whether they embark on treatment or not. And that's very much the person and their loved ones need to be engaged in this decision. And as I've mentioned, notwithstanding the statistics of risks, a proportion of patients are going to elect to say, look, this was such a frightening event, I want to start treatment, and I respect that. Other people will say, look, if I don't need medicine and it's costly and it has potential side effects, I'd prefer to wait, thank you very much. And so that's an individual decision. One thing that is very important, though, with respect to that decision is the patient being aware of the fact that starting a medicine, whichever it may be, is no guarantee of complete protection. It's not like an insurance policy where you're suddenly safe. The other thing that's worrisome that plays out very commonly is after an acute and frightening event, some people may embrace the idea of starting treatment to begin with, but then months pass and nothing happens. And they're thinking, well, do I really need this treatment anymore? Or maybe I'm better. And then they say, well, maybe I think I'll just stop it. In fact, this plays out time and time again where you catch up with a patient 6 months later and they'll confess, oh, by the way, I stopped that medicine after about 4 weeks. The important thing there, though, is in Australia, at least, and with driving, if somebody's been taking medicine and you see them 6 months later and they're seizure-free, they'll ask you, oh, well, I suppose I can stop my treatment now. And they say, oh, well, no, well, if you want to start driving, you need to continue this treatment because we don't know whether you're seizure-free because the treatment is essential or you didn't need it. And so, in fact, getting back to driving and doing activity off medicine takes longer if somebody's actually elected to start treatment because you need a period off treatment to ensure that you don't need it. So these are issues that are discussed with us on a daily basis, and the acute fear after a seizure often moderates and people will elect to stop their own medicine. This is after a single seizure I'm talking about. Now, Gagandeep has been telling us about the very important issue of regular seizures, and there is another story completely. Here, it's a matter of the people understanding, and this requires not just one interview or one discussion. No seizure medicine, no protection, because people will get the misinterpretation that it's like a course of antibiotics. I take it for 3 months and then suddenly I don't need it anymore. And I explain to them, you know, I take a blood pressure medicine. If I don't take my blood pressure medicine, my blood pressure goes up. And so no medicine, no protection. And that, as we all know, and this nuts and bolts stuff is far more important at that and gaining the trust of patients and their family than all the high-tech stuff, I think. And this is where primary care, as Gagandeep, I know, embraces totally, is so pivotally important, whether that primary care is through a GP or a highly skilled community nurse or whatever the resources allow.
Thank you, John, for very comprehensive and full of wisdom's answers. As you mentioned, beside the primary care, I think some of the patients' encounters is with the general physicians and emergency doctors. They may benefit from the same cause as well. So I think the next question will be more to Chien about ASEPA, although it's asking about neurosurgery or neurosurgeon training, but I think Chien can explain ASEPA in a more general scopes.
Yes, sorry, maybe I need, yeah, more than 5 years, yes. About the training course that occurs every year, or plan one or two course, especially for neurosurgeons. So I think the detail, we should have a more announcement from our network. Yeah. So if you need more detailed of the information, I think I can have some draft into the maybe I will make email and pass to the participant if you want. And I think the question is there scope to train a local neurosurgeon for epilepsy surgery by ASEPA? Actually, we have a committee of neurosurgeons, and they have a great project in Mongolia. Yeah, Mongolian, and they helped to do the first neurosurgeon epilepsy surgery in Mongolia recently. So I think we have the connection between ASEPA and our region, and I encourage our member to use the connection in our in any way to contact us, even to me and the chair of course Derek. So we will find a way to help you to find the right way to train the local neurosurgeon. We can plan any project for this. Yes, there's a sample what's going on.
One thing that I should add to that, Chen, is that ASEPA, the Asian Epilepsy Academy, with the help of the Neurosurgical Task Force led by Kensuke Kazai and Kawai and Sarat Chandra, offer 2 epilepsy surgery training fellowships per year. And when it comes to epileptology, that is neurology training, we offer a minimum, thanks to the support of the ILE, of 4 educational fellowships a year. And so these are available. And we're very lucky to have important training institutions throughout our region, as Gagandeep so well described, which are host institutions that can assist in this training.
Thank you, Chien and John,
Thank you, John,
for the explanations. Of course, those who are more self-learners can always join ILAE Academy, which is which there are multiple stages as well. And currently we have 4 task force of 4 groups. The first one is ASEPA group on general epilepsy training. As John mentioned, there's epilepsy surgery task force on epilepsy surgery, and there is pediatrics task force on the pediatrics, and the global outreach task force on the treatment gap or general epilepsy course for general doctors as well. There is no other questions in the Q&A. We can open the floor to the participants if you want to ask live, or the speakers if you have any other things to highlight. Please feel free to do so. If so, Gagandeep, is there anything you want to highlight and talk about?
No, it was just great actually to have a recap of the entire talk. I loved John's talk when I listened to it first, and equally this time is fantastic. And I think Bejoy's talk was also a complete tour de force, if I may say, of the neuro imaging spectrum of epilepsies, and particularly difficult epilepsies. So it was thoroughly enjoyable, and I think I simply summed up what the educational resources are, and I'm extremely impressed by the the huge amount of resources available for and by the Asian Oceanian people. So it's not just for the Asian Oceanian people, it's by them also, and most of it is by them. So it's most of it is indigenously developed. The ASEPA EEG courses also, I think I did not speak much on the ASEPA EEG courses certification exam, and that is also something like a shining star on the Asian Oceanian region, and that is something that has helped a lot many people in their careers in EEG and in clinical epilepsy. So I think there is a lot many things that have been going on, a lot of things, and the future is also extremely bright. When I have my neurosurgeon, and we were talking about a neurosurgeon, and the neurosurgeon in my institute trained through an ASEPA fellowship. So he went to Sydney many years ago, spent 3 months there, and came back, and we continued our epilepsy surgery program development after that. So I think the opportunity, someone did ask about the training opportunities for neurosurgeons. So I can say that the neurosurgeon in our institute, clearly availed of the ASEPA fellowship many years ago, and we are doing very well in terms of our surgical program. So I think all of this, this is a wonderful opportunity, and particularly these seminars, and getting these seminars across again is just not a recapitulation for all of us, but it's tremendous. Some of the gems, it's always worth listening to them again and again. And I think John's lecture is one classic, which you can watch that movie again and again and again and again. I'm very fond of watching James Bond movies again and again, but I'm equally fond of John's talk on first seizure. So thank you. Thank you so much for that. And thank you, ILE Central, for getting these seminars all over again. I think they've served what they're meant to serve. Yeah.
Thank you, Gagandeep. I totally agree with you. Listening to John's talks is very, not only knowledgeable, it's also a very it's a repetitive learning, and always something new will come out along. So John, any things to add on or to mention?
No, only that to echo what you've all said, and Gagandeep in particular, that we're an extended community, and we are friends and neighbours, and this is the way it should be, and we learn from each other. And as Gagandeep said so eloquently in his talk, we need to have a education and training that has overall similar goals, but is fit for purpose to deliver the best care available in different environments, whether it be in the many different countries in our region, which have different resources and different priorities. And this is, we're walking this journey together as we will continue.
Thank you, John. How about Chien? Anything else to mention before we end?
Yeah. Sorry, I'm another home minutes later. Yes, so appreciate that refer the John's speech. Yeah, because I'm the chair of the John's speech and in India. So I'm so surprised because I got something new from your speech again. And of course, the Gagandeep have a so comprehensive tell us and the basic educational program in our region. So I think it's our member will working on hard in the following years. And of course, because you, because John, because Kheng-Seang, and all of the member, we were working and on continually. Thank you.
Thank you, Chen. So thank you everyone for joining this talk.
Yeah.
Hope to see you all again. This is the 6th webinar. I heard there is no subsequent webinar after this, but we will looking forward to meeting you again in the future ASEPA course or ILE Academy training or courses or in the future AOEC, which will be next year in Kuala Lumpur.
Yeah.
See you everyone.
And, thank you.